I think that we're okay to start. Hi, welcome to the 4 o'clock session of Transplant Families Conference. We're happy to bring to you today about a 40-minute conversation about smoking, vaping, and marijuana use, having the conversation before it starts. I'm Katherine Robinson. I'm one of your moderators today. I am from Atrium Health Levine Children's, and I'm a pediatric heart transplant coordinator. We have 3 dynamic speakers that are going to share different aspects of this type of conversation. And without further ado, I will let Donna, our other moderator, introduce the first speaker. But I do want to ask that we, and remind you that we are going to do Q&As at the end of the 3 speakers' conversation.
Hello, everybody, and welcome. My name is Donna Lee. I am a heart transplant nurse practitioner at Stanford Children's Hospital and also a member of the Pediatric Heart Transplant Society's Liaison Committee, along with Katie. I will be serving as the other moderator, and today I'm very happy to introduce our first speaker for this session. Dr. Vernat Exil is a pediatric cardiologist and clinical professor at St. Louis University and Cardinal Glennon Children's Hospital. He helps to manage cardiomyopathy, heart failure, and transplant in children. Dr. Exil's research includes the cardiovascular effects of tobacco use in youth, as well as studies on transgenerational effects of tobacco use in pregnancy for the American Heart Association's Tobacco Regulatory Research. Please welcome Dr. Exil.
Thank you, Katherine. Thank you, Donna. And I thank PSTS and the families for inviting us, for giving us the opportunity to talk about this subject. This is actually a subject that's of importance, given that our families. Can I keep going, or is Simone going to introduce herself? So I was saying this is a subject of importance, given that children as early as middle school are getting pressured by peers to engage in those habits. I thank the families for inviting us to talk about this subject. It's about since 2007, I think, after discovery or invention of vaping products of different forms, this has become an issue, a major health issue. I have no disclosures. So my research interest, as Donna stated, is in the heart effects and lung effects of tobacco in mice and human. We do the mice because it's very hard to experiment with the humans, with patients, and we have some data about human being as well, but most of the data today is about surveys in children between 13 and 17 years of age, in terms of the use of these products. Where do they find them? How do they find them? And I don't go a lot into the reason why they do it, because there's much time, and I did not talk a lot. I'm not talking a lot about the heart and some of the molecular biology that behind the effects, but the zest of the objective is to talk about mostly when parents should start talking about this product with their children. So I'll give a little bit of background. I'll give some of the scientific data we have collected, and then the last question I want answered. I want parents to see, based on my last slide, when do they think they should stink? Because I think each parent is different, each family is different, and they have to be able to decide on their own, each family, when it will be the proper time to do so with their children. As you all know, the last 50, I would say 60 years, there have been a lot of progress made in terms of cigarette regulating these products. We have learned a lot about this product over the years. The tobacco itself caused about 500,000 deaths in the US. It's about 5 million deaths worldwide. And compared with people who never smoked ever in their life, people who smoke have an average loss of 13 years of their life in men, and about 14.5 years in women. But all these regulatory measures we have done as a society, the last 50 years, we have actually fallen back because of vaping, the vaping invention, the vaping epidemic. And these reports that I just mentioned do not mention how smoking even affect kids or babies during or mom when they smoke. About 10 or 11% of mothers continue to smoke throughout pregnancy, or smoke the first trimester of pregnancy when they don't even know they are pregnant. And this is the time when the heart is being formed and all the organs are being started. About close to 19% of pregnant moms continue to smoke toward pregnancy in some setting and some data, depending on the state where you are at. So tobacco causes lung problems, COPD, asthma in children, cancer, you all know, and children and adolescents actually have still developing. So for patients who have transplant, there is a lot of data to suggest tobacco products cause inflammation. They have more eczema, they more dry skin because they have Th2 polarization. So tobacco product cause more of that. They have mitochondrial DNA damage that can cause cancer and a change in mitochondria, which our research program is interested in. Next slide, please. So the zest of our talk today is about the effect of e-cig. This is funded by the NIH and the AHA. We will look at the effect of these products in children and in mice. We're looking at kids of 13 to 17 years of age, and we try to understand what other things, how these products affect the children. The people who are selling these products sell them as safer products. They are safer than tobacco, they argue. In some healthcare system, they are advising pregnant women to stop smoking by using these products, and people end up being dual users. And the FDA and the CDC actually have done a study that showed about that's about 14% of high school students. That's about the number we get to. About 3% of middle school students, depending on the setting, have been using these products. Actually, when they get interviewed and they said, well, have you used these products in the last 30 days? And the data, when you get to be college students, is about 25 to 30% in some settings. Next slide, please. So the previous slide, I didn't mention the fact that about 2.5 million children have become addicted to these products in the last 3 to 5 years. 2.5 million children. In some setting, they mentioned 3 million children are using these products. They're using them in school. They don't smell. They use them in church, in different temples, the synagogues. Because they don't smell. In the high school, they use them in the bathrooms. If you talk with your patients, they tell you, when I go to the bathroom, everybody is vaping. They go to parties, they vape it. And the parents don't know, are oblivious, because they look like flash drive, they look like pen. As you can see, this I took that from the CDC website. They come in many shapes. They are battery operated. They come with liquid inside. The liquids contain one of those pods can contain what the equivalent of 1 pack of cigarette. So when children smoke those, a child is smoking this, they think they are not smoking a lot, but they're smoking a whole pack of cigarette in one of those little devices. They have different names for them: hookahs, e-cigs, mods. My patients tell me, Dr. Exil, you are behind. These names are no longer being used. We have new ones because they get invented. New ones are invented every couple of years. Next time, and then maybe depending of how they look like, they call them vaping. So this is data in mice. I won't spend a lot of time in it. This is how we use to assess patients for asthma. We give them a product that's called methacholine. It's methacholine challenge. We give different doses. We cannot do that with the children, but we do it with the mice, and show that the resistance of the lungs is higher And we use two products that are very common in the market. One is Virginia tobacco and one is menthol that the kids love. And now they have all different flavors. Some of the flavors have been abandoned, mangoes and cherry, etc. And they have names like people from out of space, stars, to make them cool. They look pink. Some of them look like candies. And the long compliance is reduced, and the elastance, which is the reverse of compliance, is increased in those patients, in those mice. And the same thing here. Pulmonary mechanics measure different ways with these products, different doses of methacholine. We can show the mice have the lungs are not normal. Now let's go to the patients. So we said, well, if it's true, what happened with the patient? Well, we can look at FEV1, forced vital capacity. We look at patients when they have asthma. This is data we collected in 1 month, or 1 month in the summer when kids are out of school. We decided 1 month we're going to interview kids, and the data I'm going to present about, it's only 50 children, and we're still collecting children. So the survey, for the sake of the product of the grant, you can see the vital capacity in the children who are users, who have used in the past. That doesn't mean they are currently using. They have used in the last 30 days. It's lower compared with the patients who never use. And of course, some of the kids don't tell us the truth, and we can show that in the urine. And the FEV1 also is reduced. Please, next, please. And this, we measure airway resistance. Small airways, big airway resistance is also changed compared with kids who use compared with kids who never use. Next, please. So what brand do they use? They use Juul. That's what's very common. They use Airbar, Porsche, and some of them. The reason I put this slide is because most of the kids don't even know what they are smoking. When you ask them, I don't know, somebody gave it to me. And it's vaping. I don't know the name of it. I don't know what it is. In fact, they may not know what it has. Some of them may contain marijuana and other products. Please, next, please. So we asked them, how do you get it? Someone gave it to me. I bought it from someone. Sometimes they exchange it for a pen. Someone just offered it to me out of nothing, or I bought it from somebody, and then some other miscellaneous reasons. Next, please. And then, so we asked about the COVID questions. So think back when COVID was there. So that's one of the part of the grant. We get a supplement to see what happened before and after COVID. What happened? What did the kids do in COVID? Did they have access to this thing? Of course they had. They had access. The concerning thing, these are very few children who had access to products that are more, and they tended to be the older children who are using cocaine and opioid, and they will tell you, we only use it one time during the pandemic. But the most important thing is that they had more access to alcohol during the pandemic for some reason. So there is a tick in alcohol use after the pandemic. Next, please. And then, but the good news, I don't know how to call it good news. At 13, when we asked the kids at 13 years old, they tell you, I use cigarette, alcohol, and very few kids. So most of the kids are not using anything at the age of 13. That's something actually that's important to us. We think the time to be able to talk with them about it maybe before they get to high school. Next, please. So I have this, I attached this, and I hope we can make this available to our families, but this is online from the CDC. This tobacco is not good for children. It's harmful to them. A great number of children and even middle schoolers are using these products, which is not good. Since 2014, we have had an epidemic, and parents don't know. In fact, about 14% of our patients are using it, and most of the parents don't know. The vast majority of kids who are using these products, they see it from media, from not TV, but other media. They get access to it. So we think that all the children or kids, we think if they have a problem, they should have access to quitting. So the reason for this session, how do we reduce harm? Because they're going to try it. They're going to try it 1 time or 2 times, but how do we prevent them from using it more? And I think the discussion has to start at home at some point. Thank you very much for inviting us, and thank you for PHTS and the chair for and NIH for giving me opportunity to do this research. Thank you.
Thank you, Dr. Exil, very much. That was great. Now I have the pleasure of introducing Mary Chandran. She is a clinical pharmacist practitioner at the University of North Carolina Medical Center. She specializes in kidney and liver transplantation in both pediatric and adults. She has a very strong interest in assisting young adults as they transition from the pediatric world to the adult care transplant model. Thank you, Mary.
Thank you for the introduction. So for this part of the presentation, we're going to focus in specifically on marijuana, which of course can have a smoking component to it, as you just heard, but also other ways to be used. And so I really want to focus in on what does it mean to use marijuana after transplant, and how do we work with this with our children and our young adults. So what we'll discuss specifically is the evolution of marijuana use. It certainly has been a relatively changing topic in recent years. And so I want to highlight those changes. There's a lot of abbreviations and terminology, so I want to decode some of that alphabet soup for you all. And then specifically when we think about transplant and the use of these products, I want to break that down into considerations for pre-transplant use and then use after transplant. So in terms of the legal status of marijuana, access has risen and continues to rise. And so if you look at across the United States, 21 states have currently legalized recreational use of marijuana, and 37 states have legalized the medicinal use of marijuana. And so often medicinal use will be abbreviated as MMJ, or medical marijuana. And so these are products with a medical indication, in many instances with the use of a medical marijuana card or under the supervision of a provider. And that these, based on the state and the legalization status, may be available to patients 18 years of age or 21 years of age. Of note, however, at the federal level, marijuana is still considered illegal and is a Class 1 controlled substance. However, it is at the state level widely used and accepted as a legal status in many places. Interestingly, society has fallen along with this trend. So Gallup polls that are used to assess social acceptance or how people feel that it should be legal is also on the rise. And so what you'll see here is actually in 2013 was the first year that social opinion, or the opinion of poll respondents, is the majority flipped, and from being opposed to the legalization of marijuana, it actually flipped towards being more pro-legalization of marijuana. And you can see after 2013, that's continued to rise, with most recently 68% of respondents actually in support of marijuana legalization. So you can see that, in a social setting, it's really becoming more acceptable, more available, talked about, known, and so on. And something I found quite interesting is when those poll respondents were divided into major groups based on age, gender, income, education, politics, or religion, this favorable viewpoint withstood. So essentially, across all groups being asked, do you think marijuana should be legal? Oftentimes you're going to get more yeses than nos. So of course, our young adults and our teens are equally going to be influenced by this and are likely going to be more and more interested in at least exploring these products, asking questions about them, wanting to know more. And it's also more available to them because there's legal ways to get your hands on these drugs. Not necessarily if the person that's underage is getting it, but it's going to be more readily available for older people to purchase. So also, I'd be remiss if I didn't talk about CBD, because I'm sure if you've walked into a store in many states, in many places, you're going to see this at the register, on counters, signs advertising CBD stores you can pop into. So what is this all about? So CBD is a component of cannabis, so cannabidiol. It's one of the compounds found in the cannabis plant. And when you think about the benefits of medical marijuana, all of the things it's claimed to do for anxiety and nausea and so forth, that's the CBD component of marijuana that people are talking about. And so in 2018, the Hemp Farming Act actually made it legal to use hemp-based products that have CBD in them And a lot of those things are for hemp used in textiles, for fibers, oils, and so on, but also it allowed and opened up the door for CBD products. And so you can see across the country, CBD is available and it's legal, but there are perhaps varying conditions from state to state. But in general, this is a federal product, a federally legal product within the United States. So let's take a step back and answer the question, what is marijuana? Because I think this can get quite confusing. So if we start with the cannabis plant, so cannabis sativa, within that plant, there are several compounds, and these compounds are known as cannabinoids. The two that we're most familiar with and that we talk about most often are CBD and THC. So THC, that's your delta-9 tetrahydrocannabidiol. That is the product that makes you high, or that's the compound of marijuana that's psychoactive. That's what people generally think about when they think about marijuana. The more THC within the plant of the cannabis, or that cannabis product, is going to have a stronger high or a greater psychoactive component. Generally, anything with 1% or greater percent THC is thought to have that ability to cause a high. And then comparing that to CBD, which is the other major component, which is cannabidiol that we just touched on, this does not have psychoactive properties. And so CBD is thought to be the component of cannabis that is intended for medical conditions. So anti-inflammation, anti-anxiety, anti-pain, anti-nausea, and so forth. So if you think about the two main parts of the cannabis plant, we have CBD, which is more medically indicated, and THC, which has those more psychoactive components. And distinguishing these two is going to be very important when you think about what products are available and at the hands and fingertips of our young adults and our teenagers. So let's stick with the right side of this picture. If you take cannabis sativa, it can become available as the marijuana plant or the marijuana flowers or so forth that people will use to smoke or ingest. And so marijuana, by definition, is a cannabis plant that contains more than 0.3% of THC. So marijuana has more THC and is therefore likely to cause a psychoactive effect or a high. This is the product that is federally illegal, but does have variable levels of legality across states. And when you think about marijuana, you can use it in a range of ways. So inhaled in the traditional sense of you roll a joint, you smoke it through a bong, is sort of what most people think of. But there's also, of course, edibles. So we think about brownies and gummies and things of that nature. But then there's also topical forms that can become available as well. Comparing that to the other form of the cannabis plant is hemp. So the main distinction between these two is how much THC is in them. So in hemp-based products, you're looking at a low level of THC, so 0.3%. Therefore, it's likely to not have a psychoactive component. It's legalized based on that 2018 Hemp Act. And then general, when you're buying CBD products out in the community, when you look at oils or capsules and gummies, these are often going to be hemp derived. So something advertised as CBD alone is likely medically indicated based on what it's being sold for and not psychoactive, whereas marijuana has both THC and CBD. So there is still some of those CBD benefits there, but there's also the psychoactive component as well. So hopefully that helps to clarify some of those terminologies and things that people may be asking about. Is CBD safe or is marijuana safe? So hopefully that helps there. Now let's talk about the safety of using these products. The main caveat that I want to throw out there is we don't know much about them. The main reason for this is the federal illegal status of marijuana significantly limits how it can be researched. You don't see large randomized clinical controlled trials of these agents because they're not readily available to researchers. As well, without FDA approval and without FDA regulation, what's out there on the market, what's in dispensaries, what's on shelves is very much lacking in standardization. So the label may tell you it contains a certain percent of CBD or a certain percent of THC, but there's no governing body looking into that. So it makes it very hard to compare one product to another or one experience to another, because we really are comparing apples to oranges. In terms of safety with use, so you just heard about all of the negative impacts of smoking. So certainly I'm not going to ever suggest someone use an inhaled version of these products, and I put that as the least safe way to use them. Topical would be the most ideal or most safe because there's very limited absorption into the bloodstream. And then ingesting the products does increase absorption and exposure, but it does avoid the inhaled risks that come with marijuana use. I will also add that something that often comes up in discussions, and I wouldn't say is necessarily data-driven, but is still thought to be a big concern, is the infection risk with smoking these products. Because these are essentially agricultural products that are being grown in various situations, not well regulated, it's really quite hard for us to say that they don't contain bacteria, fungus that would be very concerning to a patient who is immunocompromised after transplant. There may be pesticides on them or other additives that we're not aware of. So in general, inhaling these products beyond the risks of just smoking in general, I think does bear a big burden for risk of infection or toxic exposures to other things. So overall, I think across the board, no inhaled products would ever be considered safe in any capacity. Other things to think about is short-term versus long-term use. Is this something that someone wants to try at one time? Is it very intermittent, small doses? Or are we looking at more of a substance abuse issue where it's being used in a long-term and chronic way? Again, we don't know enough to answer that clearly, but I think that again would be something we would want to think and know more about. One of the bigger safety points that often come up when I'm thinking about this and talking with patients is, how do these agents and these substances impair our judgment, particularly if we're talking about marijuana that's psychoactive? If you're having impaired judgment with using these agents, does that mean you might miss your medications? Are you going to miss appointments? Are you forgetting to get your labs drawn? If that's happening, of course, that's very problematic for the long-term health of the patient and their transplant. So of course, that's something we would want to be very thoughtful about avoiding. I do add this, which I found quite interesting. We certainly think that there's impaired judgment, but perhaps it's not as bad as we think. And so this is a statistic I have with regards to car accidents, I found quite staggering. So a study looked at car accidents in individuals or drivers that were using cannabis and found that it was up to 2 times higher risk compared to folks who were not impaired, which is high. 2 times is still more than any of us would like to see. However, compare that to texting and driving. Texting and driving increases the risk of car accidents 23 times compared to someone who's unimpaired. So in the grand scheme, it may not be that as problematic as we think. And I imagine many of us at some point in time have texted while driving, and that is certainly much more of a concern. So it does put things into perspective a bit. Now let's talk about the potential benefits of these agents. Again, they're not well studied. They haven't been done in randomized controlled trials, but we do have some case-based studies or small studies from centers that show there are potentials for pain relief. And in fact, states that have legalization of medical marijuana or recreational marijuana for that matter, have actually shown that there's decreased opiate use and opiate overdose in those states. Now, there's no direct correlation or cause and effect that can be drawn from this, but perhaps using these agents for chronic pain may actually help us to alleviate the use of opiate type medications instead. There's also potential benefits for anxiety, nausea, vomiting, increasing appetite for patients who need to gain some weight, or patients that are struggling with insomnia and needing improved sleep. So potential there, but really not enough to back this up at this time. The other thing, particularly that we must mention for transplant, CBD and THC have a lot of potential to cause drug interactions, particularly with the transplant medications that we are commonly using. So they actually impair the breakdown of these medications in the body. And the medications that have been shown to be impacted include ones you're very familiar with, I'm sure, So tacrolimus, cyclosporin, sirolimus, and everolimus, also common blood pressure medications, some antibiotics, and even blood thinners. What CBD and THC have been shown to do is actually increase the levels of these medications in the body. And by doing so, if the levels are higher than intended or desired, we end up seeing increased risk of side effects or exposure, which can be harmful to patients if not caught and fixed in a timely manner. If you're a visual person, I think this sort of speaks volumes here. So what I'm showing you is a single patient experience, and this was in a patient using tacrolimus who needed to use CBD to control epilepsy. So if you look at the left side of the screen, you'll see what the patient looked like before starting CBD. Their tacrolimus levels were in goal, and they were taking a dose of tacrolimus 5 milligrams twice a day. After CBD was provided to the patient on a consistent basis, so they were using this daily, you can see the tacrolimus levels shot up. And in order to get the tacrolimus levels back to what they should be, the dose had to be reduced all the way down to 1 milligram twice a day. So really, a 5-fold difference in the dose was required, or reduction was required, showing just how impactful that CBD exposure was on the tacrolimus levels. So it's certainly not insignificant, and it's something that we know about. Do we fully understand it? I don't think we're there yet, but we are able to at least understand and try to anticipate these changes in patients using these drugs. So in the pre-transplant setting, regards to people who may be interested in trying these medication or these agents or compounds, some things I think that should be really considered are how this may impact transplant listing status. Each transplant program has their own requirements, and these will differ from state to state, substance to substance, but often programs can be quite strict about illicit substances. So opiate use, marijuana, alcohol, and so on. If in many cases, surveys that have looked at transplant programs have shown programs want to see periods of abstinence from these products. They may also distinguish medical versus recreational use to be acceptable or not. And of course, the state within which that transplant program operates will dictate some of these decisions. The reason I bring this up, though, is if you're using marijuana prior to transplant and you're trying to get on the transplant list, this may play into how quickly you can or cannot be listed. And so it's something to think about, but also be transparent about with the transplant program you're working with, and also being familiar with what their requirements are. On the flip side, after transplant, I think it's very important here is that communication is key. We still don't know a lot about these products, but we know they're available, we know they're out there, and we know that young adults are interested. So in many cases, we have to sort of meet our transplant patients in the middle. I think that, of course, we're going to say we don't want anyone using them outside of their legal status in your state. So no one under the age of 18 or 21 should technically be using these, but we really also want to be realistic and acknowledge that we want to know about these things. And so we want communication to be clear. We want it to be a conversation point with our patients, but we want to explain too some of the risks that we've already talked about. So we don't have a lot of data in studying this in the safety of it in transplant. What I will say is that the small studies that have come out recently have shown that the risks for infection, death, or non-compliance that we sort of assumed were there have not come to fruition. So it may not be as unsafe as we necessarily think, but we still don't know enough, and we want to do this in a controlled and thoughtful way. In general, we want to tell our patients, do not smoke these things. Don't inhale it, don't smoke it, don't vape it, in any capacity. If patients can get it legally, they're motivated to use these products in a safe way, then we want to be very consistent about them. Use reputable dispensaries, use consistent products in use. Tell your transplant team how much you're using them so that we can be very thoughtful about checking your drug levels, adjusting things as we need to, so that we can work with you to make sure everything is being done in a very safe way. But I think one of the biggest takeaway points from all of this is that we still don't know very much, but the products are out there. And we're learning day by day, as more and more information becomes available. So I think really shared decision-making and communication is key here. Big takeaway points is, of course, marijuana, THC, and CBD use are on the rise. Acceptance continues to rise. So this isn't something that's going away. These are certainly questions that our young adults are going to ask us about. They're going to be presented with opportunities for these. And so we want to at least give our young adults them as much information as we can to, equip them with to make decisions about how to proceed. We still do need more research, of course. And then when it comes to should or we shouldn't use them, I think we have to think about ways to do best judgment. So share decision-making with the transplant team, talk to your team about your interests, your questions, before, using them sort of haphazardly. Be transparent if use is there. If a team wants to know, why did your tacrolimus levels go up? Well, maybe it's because I tried marijuana over the weekend, let them know. Think about the risks and benefits of why someone's interested in using them, and then limiting use to topical or edible forms in all instances would be recommended. So with that, I'm going to pass it off to our next speaker.
Thank you so much, Mary. I am very excited to introduce our final speaker today. Dr. Simone Lebeuf is an adolescent medicine pediatrician at the University of Alberta Department of Pediatrics and Stollery Children's Hospital in Edmonton in Alberta, Canada. She provides care for a broad group of complex youth. Dr. Lebeuf's research focus includes adolescent-led families, gender-diverse youth, vaping, and clinician health and well-being. In addition, she collaborates with providers across specialties to provide medical education to enhance the care of children and youth. Please welcome Dr. Lebeuf.
Thanks so much for having me here today. I'll be sharing kind of part 3 of our talk, kind of pulling things together, how to have these conversations about substance use in the transplant setting. It's a little more general, not specific to smoking or vaping. It's general conversations about how we're having topics about substance use. So I really love this quote. One of the big things as a parent, I have a teenager as well. So I think it's really important to listen to anything your teen is saying. My teen wants to talk about this book or a TV show I have no interest in. That's okay. I'm tuning in, I'm listening in, because it seems like silly stuff, but it sets up that foundation to talk to teens about serious things. Having like the sit down kitchen table lecture with a teen isn't really going to get your point across. So you have to wait for those opportunities and ask a lot of questions, get really curious, get your teen's perspective. You should actually do really little of the talking. So this might look like, a teen says something like, oh, this character on a TV show is smoking cigarettes, and you say, wow, what do you think about that? Tell me more about that. Opens the door, but if you're not listening, you're not going to see those opportunities. Confidentiality protections are a really big component of high quality adolescent healthcare, especially for sensitive topics like substance use. It is totally normal and in fact expected, part of adolescent development, to want privacy from parents. I see a lot of parents really struggle with this, especially those who've been through major medical events like transplant. You've been by your kid's side every step of the way, and all of a sudden your teen turns 13 and doctors are asking you to step out of the room. But we have to get teens ready to be independent, functional adults. And so hopefully you'll see in the teen years, we make this slow move from the healthcare team where parents are a core part of the team to maybe parents are playing more of a supporting role. And the first step in all of that is to offer to speak alone with the teen. Confidentiality generically means that information shared by the teen with their healthcare provider stays with the healthcare team. Now, the specifics of this will depend on your location and the laws in your local area, but healthcare providers do have a duty to intervene if they think a teen is at risk of serious or imminent harm. From the Society for Adolescent Health and Medicine, confidentiality protection is an essential component of healthcare for adolescents because it's consistent with their development of maturity and autonomy. And without it, some adolescents will forego care. So your teens won't have those conversations unless they have that confidential space. So for the teens in our audience, make sure you ask and clarify the limits of confidentiality with your healthcare provider. Parents, try not to grill your teen on what they talked about with their healthcare provider when you stepped out of the room, and even offer to leave. And healthcare providers, make sure you really understand the limits of confidentiality well, and offer to meet with teens without parents early on in the adolescent years. Your clinician should be screening teens for substance use regularly. There's a really nice model we can lean on called screening, brief intervention, and referral to treatment, or SBIRT. Experience with substance can vary across the spectrum, from total abstinence, never tried anything, to substance use disorder. So the goal is is to identify that individual's experience along the spectrum and then institute the appropriate intervention. One of the things I often see is diffusion of responsibility. So the transplant team assumes the primary care provider is doing it, the primary care provider assumes the transplant team is doing it, but everybody should be doing it. Teens don't see healthcare providers unless they absolutely have to. So we should take any contact with the healthcare system as an opportunity to check in. This could be a quick private conversation, like doing a head's history, or a screening questionnaire. So something like the CRAFT is one that I often use. Parents, again, make sure you're giving your teen space, and clinicians and teens, again, having that confidential conversation is really important. After screening, there's typically a brief intervention. So that could be anything from, if a patient tells me they're not using any substances, I'd go, wow, that's such a great choice for you. That's a really good way to take care of your transplant. And then if something is there's a little bit of substance use, I might ask some more questions about that, and then dive into maybe what type of intervention might be needed. A very broad overview of treatment for substance use disorders. So one of the first things I do is motivational interviewing. And so it kind of is a way to help people elicit change talk. So to help someone figure out for themselves, maybe I need to make a change around this. As human beings, we're naturally a little oppositional. So if I do something so someone says, wow, that's really bad for you, my immediate reaction is always me, no, it's not, it's fine. So the goal is really to get someone to move their own thinking, and not just for me to tell a teenager, yep, smoking is bad. Substance use specific treatment would include addictions counseling or maybe a specific therapy. If the substance in question creates a dependency to which withdrawal might be dangerous, your clinician might suggest a detoxification program. And then treatment may even include medication, which would depend on the type of substance use disorder. So for example, with smoking and vaping, I often prescribe nicotine replacement therapy, can really help someone manage the withdrawal of that. When we talk about treatment, it depends on the specific substances involved. And it's really also important to understand that substance use disorders are not moral failings. There's very real neurobiologic underpinnings that can perpetuate substance use. So it's important to look at treatment like you would for any other health condition. If a teen had a medical problem like asthma, you wouldn't just ground your teen, you wouldn't just tell them to stop, wheezing. You take them to the doctor, you take them to see their healthcare provider and learn more about treatment options. So treat substance use as the same kind of concern. It's not a willpower issue. I'll briefly talk about this. Harm reduction is an approach, it's a practical set of strategies to reduce the negative consequences associated with substance use. So in this setting, we're saying substance use is already established. It doesn't minimize or ignore the real and tragic harms that can happen, but it's choosing to work to minimize the harmful effects of the substance rather than simply ignore or condemn them. And it emphasizes the measurement of health, social and economic outcomes, as opposed to drug consumption as the endpoint. So some things that I might suggest is if someone's using alcohol, for example, in the transplant setting, I'd want to make sure that they're still taking their medications or talking to their doctor, or that they're using with a safe friend. And you probably don't need me or any research studies to tell you that transplantation can be really tough on mental health. But just to confirm, when we do compare to like a general population, adolescents post-transplant have higher rates of things like anxiety, illness-related anxiety, PTSD, depressive symptoms. There's a lot of trauma that happens within a transplant for some teens. In the initial stages of substance use, a teen might be using a substance to cope with their mental health. And so it's definitely an unhealthy coping mechanism, but it is what the teen might have available to them in their toolkit. So we need to empower them to use other more appropriate tools, and then treating things side by side. So concurrently treating substance use disorder alongside things like depression, anxiety, PTSD, or neurodevelopmental issues like ADHD can be a really important step in allowing a teen to move ahead with their life. And those are my thoughts. I'm happy to share my references and discuss with our team any of the questions that may have popped up.
Thank you so much, Dr. Lebeuf. Now we'll move into we received some questions during the talk, some of which have been addressed. The first one coming in, I don't know, Dr. Exil, if you could maybe try and help address, how can I know if my child is vaping? Are there smells or actions to look out for?
This is a very good question, and it's a question that we encourage parents to ask questions. In fact, the AAP has a American Academy of Pediatrics has some helpful advice in terms of plainly asking whether they have a friend who uses it, or have they used it, have they tried it. It's very hard for parents to know. Because it doesn't smell, it can be, and many times they do it in school, they don't do it at home. During the pandemic, they do it in their bedrooms, because they were always at home in some settings. It's very hard for parents to know. That's a good question.
Just to piggyback onto that, I'd say the number one thing I hear from parents is money going missing. So that's the one thing you might actually know at home. I also see lots of anxiety from vaping. So you might see like a really big spike in their anxiety, because nicotine's a stimulant. So you're going to see this really big anxiety spike in a lot of kids.
We have a question. I'm not sure it's directly towards anyone, but someone asked, my child wants to be a normal teenager and try all of these risky substances. How can I explain the risks so they will understand?
Maybe I can start with that one. So I would say having the conversations really early is important. So before they start, so before you think that they might be exposed, like we're seeing in those slides from Dr. Exil, like even age 13 kids are starting to hear about it, or they'll see it in middle school, or other people have heard. So if you need to start having those conversations really early, and American Academy of Pediatrics and Canadian Pediatric Society both have some really great parent-facing resources that can be helpful. And then for vaping, I'll drop it in the chat box, but the Solve Mystery Toolkit was developed by a resident here in Edmonton, and it's facing teens, and it's meant to help them understand more of those risks of vaping. It's not specific to transplant. And teens do have to push back against their parents a little bit, right? Like you have to let them be teenagers in some ways, but not every teenager is using substances. Actually, the vast majority of teens are not using substances. The overall rate of substance use is going down compared to previous generations. And so let them push back against things like their bedtime or about who they're hanging out with. I have like an ongoing, my daughter pushes back, I want to read past my bedtime. I'm like, no, you can't read. Like it's created so that she has that pushback ability.
Thank you so much. Does solid research exist about the effects of vaping, smoking, alcohol, and drug use, specifically on post-transplant patients? I think anyone can speak to that. Could chime in.
Donna, you want to speak up to that, you said? Miss
Oh,
Patricia?
if any of
Oh,
any
okay,
of
okay.
you, yeah.
You know, it's we don't have enough data. I mean, one of the reason we got this the funding was the argument that overall teens were using these products, and as Simone said, we don't. I mean, about the vast majority of children are not using these products. I mean, from the cohorts we have, it's about 14% of kids by the time they get in high school who are actually using it routinely. Routinely meaning once a month. It's not like they're using it when they go to a party, when they go to, but there were like 7 kids out of the cohort we had who were actually using it heavily. I mean, the urine tests and the blood tests suggested that, and as Simone said, they had issues with anxiety, they had more issue with it. So but for the transplant cohorts, we don't have enough numbers of patients, and from our cohort, we don't have enough numbers to have statistics. We do have research going on with the mice, where we are doing a number of things to assess with how it affects immunity and how it affects the cytokines. That we have some of the data, and epigenetically, it's interesting because at least in the mice, if the grandmother mouse or the great grandmother mouse smoke, when the children and the great-grandchildren never exposed to smoking, the lungs are not normal, the hearts are not normal, the liver, so these data suggest that maybe in transplantation, with the combination of marijuana plus, as you saw, that the tacrolimus level will go higher or cyclosporin level will be higher. It's maybe possible they develop more cancer over time, but we don't know that. But the eczema idea, the Th2 polarization, kids with immunosuppression get more eczema and dry skin anyway. Cigarette does the same thing. Does vaping kids get more dry skin?
I would say from adult data, we do have some more experience with chronic use of some of these agents. Now, certainly there's no randomized control trials. We don't have people that have to smoke versus those that don't, or drink or whatnot. But we have a lot of observational data, and chronic use of nicotine and smoking is certainly associated with cardiovascular disease in the long term. Opioid substance use disorders are going to have, several, longstanding effects on our patients and their outcomes. So while we don't have very clean data in this, we do know long-term use of a lot of these substances do have impacts on our patients' long-term outcomes as they head into adulthood as well.
I want to say something about the teenagers. The older teens that I have were part of our, they are not, I shouldn't say they are part of our research program, because some of the kids we have agreed not to enroll them for specific reasons. What we find out is that the kids were heavy users of these products. They tend to have more rejection. That's been known for a long time. The only thing people don't know is are they having more rejection because they are non-compliant. They have, because if you have the use of cigarette and anxiety, the more heavy users have more anxiety. That's the data. I mean, the kids who have more anxiety smoke more. Even adults who have more anxiety smoke more. So whether that's the reason they are not taking the medication, they are non-compliant, versus because this nicotine itself is causing this, we don't really know.
Thank you very much. We have several other questions that we didn't unfortunately get time to answer today, but it just means that there's clearly some interest in this topic, and perhaps maybe in the future we could have version 201 of this. But we very much appreciate our speakers today. Thank you for your time and your experience. And thank you to transplant families. On behalf of the Pediatric Heart Transplant Liaison Committee, we are more thankful for you letting us share this session with you today.
Thank you.
Thank you for having us.